Hello, everybody. Welcome to Grand Rounds on this Monday, October 4th. We are happy to have you all here with us today, and happy as we've been trying to do this year to bring back some of our alumni for Grand Rounds. In this case, we are welcoming back Dr. Taro Minami, who was a resident through the END program, did his residency here, left to do a chief resident year at Brown, came back here, missed us too much, and did a pulmonary clinical care fellowship here, and then I guess didn't miss us that much and went back to Providence to where he is now an associate professor of medicine and of medical science and the director of their medical simulation and POCUS training over at CARE New England. And so we are thrilled to have him back. Dr. Minami, take it away.
Oh, thank you. Well, first of all, thank you so much for having me. And it's so great to be back. And thank you, Dr. Weissman, Dr. Mitaka, and Dr. Dan Steinberg. We're just chatting. It's hard to believe, like I was here 20 years ago when I first met Dr. Dan Steinberg as an observer. So it's really nice to be back here. And a picture was like 16 years ago when I was a PGY2 and I'm 9 Minsky at BI. So it's so great to be back here. Thank you so much for having me. There's a little disclosure that I am a consultant of Fujifilm, which is the ultrasound company, and also Japanese government. The reason I'm doing a consultant of the Fujifilm and the Japanese government is because I'm teaching point of care ultrasound in Kenya. I'm teaching and developing the training program for Kenyan doctors. And actually, it was this Wednesday, we have a graduation ceremony for one of the first trainees. So I'm quite excited about that. But speaking of which, February 2020, looking back, I was able to still travel to Kenya, no problem, right? And as you can look at the pictures, nobody was wearing a mask, and I have no problem traveling to Kenya. That was a nice, good old days. And a week later, I visited Kenya. I came back to the US, and I was invited to NYU to teach advanced critical care echocardiography. And these are the folks. Some of you might be familiar. Dr. Mayo in the middle, he's a guru of point of care ultrasound, my mentor in the ICU and a point of care ultrasound. So we were able to, chit chat, no mask, nobody's wearing a mask, from Providence to New York City, no problem. Then the rest of the story. It's a COVID completely changed the way we live that changed the way we do medicine. It's just amazing. It's painful in a way. That's how COVID pandemic had changed the world. So today I would like to talk about the COVID and a point of care ultrasound. So here are the 3 objectives. That's it, 3 of them. So we're gonna review the general application of point of care ultrasound. First of all, what's POCUS? So for those who are sweating, what's POCUS? And you're Googling POCUS right now, don't worry, I'll explain to you. Then learn how point of care ultrasound is utilized for patients with COVID-19. So kind of that's a main theme. And the third one is, I'm gonna talk briefly, if I have enough time, talking about some innovative application of point of care ultrasound and some exciting stuff. So let's start, shall we? So first, let's review general application of point of care ultrasound. And I know we have 10 minutes for Q&A, so I have to finish my talk in 40 minutes or 45 minutes or so. Let me try. But let me first ask you this question, right? It's a quiz, and feel free to, you often use chat section. So 2021, the year we live in right now, marks the 205th anniversary of a medical device invented. So pick up the person who invented that device. 205 years ago, somebody invented something. Who is that? That's my question. So what do you think? Who was the one who invented the device? A, B, C, or D? So feel free, for those who have direct access to the Zoom through computer, feel free to jump in, right? Or you could raise your voice. I don't know if you could do that, or you probably can't. So what do you think? So A or B or C or D? Oh,
we have D's.
oh, wow.
Yeah.
Nobody's raising hands to A or B or C or C? No? Okay. Wow, that's a smart audience, right? Of course, Mount Sinai, Beth, Israel. That's a great traditions of super smart guys all gathered together. So most of you seemingly raise their hands for D, and which is the right answer. Lennox is a guy who invented something. My next sub-question, if I may say, well, let me, by the way, close the door. So Lennox invented which device? Anyone knows? 205 years ago, which means 1816. Excellent. Of course. It's a very smart audience here. So excellent. That's amazing. So everyone here invented something. Invented some medical device here. So A is a Carl Dusek. And he's a psychiatrist, by the way. So he's a psychiatrist, neurologist. Back then, psychiatrists and neurologists are same species. So Carl Dusek utilized ultrasound for the first time in 1942 to visualize the patient's brain tumor. So he tried ultrasound to scan the patient's head. It's still quite an innovative usage of ultrasound. So that's him. A. B. Sir Godfrey Hounsfield. And you probably heard about Hounsfield unit, right? And he's an MD, he's an engineer at ME who invented CAT scan. And the very first CAT scan, believe it or not, almost precisely 50 years ago, October 1st, 1971, that's the very first CAT scan was performed. CAT scan of the head, by the way, was performed in one of the hospitals in Wimbledon, London, in United Kingdom, for which he got the Nobel Prize in 1979. And Röntgen C, he's probably, you know him. He's a guy who first applied X-ray to visualize his wife's hands. He took a picture of his wife's hands, and that's the very first picture of the hands X-ray, and for which he got the very first Nobel Prize. And the last, not the least, is Lennox, who invented the stethoscope in September 1816, almost 205 years ago. And that's him back then, 1816. And back then, auscultation of the chest, as you can see in this picture, was all through direct auscultation, meaning that you put your ear to the patient's chest. And that's how he did that. And obviously, there's a sick guy. And he has his prototype stethoscope in his left hand. And quite amazingly, so this really, impressed me. This guy, 3 years later, August 15, 1819, he already published the textbooks about indirect auscultation of the chest that sets a foundation of the pulmonary medicine. So that was like roughly 202 years ago. He published textbooks already 3 years after he invented the stethoscope. And you probably heard the word, rail, egophony. It's all from these textbooks. Well, nowadays, 1977, Chess and ATS decided not to use the term rail, but that's a different story. But those terms you might have been using today is from this textbook. That he's a father of the modern pulmonary medicine. Unfortunately, 7 years later, he died at the age of 45 because of tuberculosis. And you could probably tell how he got the tuberculosis, right? I mean, obviously, this guy probably had TB, and he got it from him, I guess. So why I'm talking about this? Hey, I'm here to learn about point-of-care ultrasound. Talk about that. Well, I can't help talking about stethoscope because it has a very similar structures. So 200 years later, now we have next innovation of the technology, now utilizing the ultrasound instead of the sound to visualize the human body. And you see me, this is actually from the CHEST, American College of Chest Physicians website, me teaching ultrasound like a 2000. And when I was a fellow, oh my gosh, I have all this black hair instead of all gray hair I have nowadays. So let's talk, first of all, let's talk about point-of-care ultrasound or POCUS and how the POCUS is defined. There's a nice review article from New England Journal of Medicine published 10 years ago. Oh, by the way, a new review article coming to New England Journal of Medicine, written by Dr. Paul Mayo. He was the ICU director here at Mount Sinai, Beth, Israel. So check it out. And Paul Mayo says Cooney, he was the critical care director at LIJ. So and now he's my boss. Dr. Paul Mayo is still at LIJ, but they just finished writing the review article at New England Journal of Medicine that should be published pretty soon. But based upon this review article, point-of-care ultrasound is defined as ultrasound brought to the patient and performed by the provider in real time. So what does it mean? So it's basically the ultrasound by you for your patients. It's not that you put the order, hey, please come do the ultrasound for my patient. No. You bring, so here's my body. I don't know if you see, you bring the ultrasound to the bedside. You who gonna do the ultrasound? You do. And for your patient, okay, so can anyone write the report? No. You analyze, you make a decision. So that really is a key. And the 3 years later, American Society of Echocardiography published a nice article which defines a focused cardiac ultrasound. So remember that comes from cardiology folks, published in Cardiology Journal 7 years ago. You know what? Maybe echocardiography is not only for cardiologists. Echocardiography might be for everyone. So that's why they published this focus. And the definitions of focus is focus examination of the cardiovascular system performed by the physicians as an adjunct to the physical examination to recognize specific ultrasonographic signs that represent a narrow list of the potential diagnosis. And I'm talking about focus, which is a part of point-of-care ultrasound, because I think it's a really nice essence about point-of-care ultrasound. It's about focused examination. It's not a comprehensive examination of the transthoracic echocardiography or TEE. You focus on few things. And you know what? It's an adjunct to the physical examination. So that's why you don't outsource your physical examination, right? You don't copy, hopefully you don't copy somebody's physical examination on your progress notes. So you do your physical examination. It's your exam, right? You don't hear murmur, it's okay, but it's your exam. And you utilize these findings to the patients in front of you to narrow down the list of potential diagnoses. So there are lots of wide variety of application. For example, it's all actually my patients, except this might be a Dr. Yaskawa's patients. But all the pictures I got in my ICU, I'm seeing the ICU patient because I'm a pulmonary critical care docs. So I work in the ICU. So these are all the pictures I obtained for my patients. So there's a huge wide variety of the applications, right? So that's a sort of an intro about point-of-care ultrasound. It's ultrasound by you for your patients. You judge the images, you make additions utilizing your own images, right? So that's the essence of the point-of-care ultrasound, and it's an extension of physical examination. Now let's talk about point two. That's the main theme. How? Okay, all right. So then, how you can utilize point-of-care ultrasound to diagnose patient with COVID-19. So let's talk about that. So you may first wonder that, hey, why you are talking about point-of-care ultrasound? I know you are doing the point-of-care ultrasound, so you want to sell podcasts, right? But wait a moment. We have chest X-ray, we have CAT scan, right? And we have stethoscope, right? So all these big, Röntgen invented chest X-ray or X-ray, and Dr. Hansfield, Sir Godfrey Hansfield invented CAT scan, right? That's why nowadays we call ABC of emergency medicine. You know the ABC of emergency medicine, or ABC of the resuscitation, right? It's airway, breathing, and a CAT scan, right? I mean, it's no, just kidding. Don't take it, right? So airway, breathing, CAT scan. So that's it. Do you have to examine? No, well, no, you have to examine. But anyway, the CAT scan is there, so you could examine the patients. Why you're talking about point of care ultrasound, right? So yeah, there is some good data about the chest radiograph published soon after the COVID pandemic. And it's sort of useful. The problem with the chest X-ray is it's not that sensitive. You see that this bilateral peripheral, patchy, confluent, band-like ground glass, consolidative opacity, but that's yeah, okay. Maybe I see or maybe I don't see, and they actually did the sensitivity. Sensitivity is 15.5%. Specificity is actually quite high. I'm not too questioned, to be honest with you, about this specificity, but okay, let's take the numbers for granted, but the still sensitivity is quite low. It's not a great test for screening, right? So these are the specific number. But what about the CAT scan, right? So once again, that's airway, breathing, CAT scan. So everyone gets CAT scan, right? I have a headache, CAT scan. I have a hang toenail, CAT scan, right? So everyone gets a CAT scan. So which they did in China when the COVID started in China. They actually mass screen CAT scan patients with a CAT scan, right? So as you can see in this picture, and it's quite useful. CAT scan is quite useful. So don't get me wrong. Oh, Dr. Minami from Brown said CAT scan is useless. No, I didn't say that. Oh, no, I said CAT scan is useful. It's a very unique, specific findings on the CAT scan, as you can see. And already radiology published the data in 2020, soon after the COVID pandemic. It's kind of quite amazing how soon all this gush of the publication came out from everyone, including myself, because everyone wanted to say something about COVID, and it's quite helpful. Look at this sensitivity of 97%. So you could say, then, okay, then why not using the CAT scan as a screening tool? That's useful, right? But interestingly enough, American College of Radiology, that, body society of radiology, says, well, you know what? You got to be really careful in utilizing CT scan for screening tool to diagnose COVID-19 infection. You got to be really careful to do that. And why is that? So apologize for the tiny slides, but it's kind of, it always comes with infection control. So you have to limit the visit of the patients. It's in a closed system, right? So once the patient's in, you have to ventilate the CT room. You have to clean up the CT itself, and you have to wait. So it takes time. It takes time. So it's not easy to perform CT for the screening tool. So actually, ACL stated very clearly that CT should not be used to screen for COVID-19 pretty clearly. in early February, March, in the published clearly in their website. It's quite amazing that the Radiology Society said so. And like I already mentioned, the issues around the infections control of the CAT scan takes time and human resources, right? Decontamination of the room, cleaning up the surface, rooms maybe need to be unavailable for approximately 1 hour, even more so. And there's always a risk of those people cleaning up the room, cleaning up the CAT scan, dealing with a patient. So they said, you know what, you really have to be careful using the CT. It's really certainly not the tool for screening, but more so utilized to specific diagnosis. So that's a key. So, all right, so you just mentioned about Lennox invented the stethoscope September 1816. What about the old, nice, classic stethoscope? And trust me, I love physical examination. I love physical examinations, and I'm even doing some research for certain physical findings. But when it comes to COVID, it may not be that easy. You probably all agree, for those who ever take care of the patients with COVID, getting to the COVID, I work in the ICU, and I have to wear these poppers. I wear all these, protections, and all this HEPA filter noise. It's very difficult to make a diagnosis or do the examination with a stethoscope. And, stethoscope may give you some illusion that you're doing something important. But, like everyone copies S1, S2, regular rate and rhythm. That drives me nuts. Seriously, so S1 normal. So tell me about that. It's always hold that, ICU residents, presentations. Oh, the S1 is a heart lung examination is normal. S1 is RR. So wait a second. So what do you mean S1 is normal? And they hate me, but okay, I don't mind. So I love physical examination, but when it comes to COVID-19, it's not that easy with all these obvious reasons. So here comes point-of-care ultrasound. And the early in the pandemic already, Journal of Hospital Medicine and Benji, Matthew, my nice colleagues, and Neelam, Sonny, and all these nice people I work together, published a nice, I wonder why they didn't include me as authors, but anyway, that's okay. So Benji wrote this article in Journal of Hospital Medicine, and they already mentioned a very nice thing. That POCUS is a perfect example, perfect tool for diagnosing COVID-19 and dealing with the COVID-19 patient. Why is that? Because no need for transfer, so we don't have to move the patients to the CAT scan room. So you probably agree those severe COVID ARDS, severe ARDS, or the people 15, 20, FiO2 is 100, prone, you can't transfer these patients to the CT scan. You could, sometimes we do, but it's risky. And can we repeat every day? Or I did the exam in the morning and in the afternoon CAT scan? No way. But POCUS can. So you can repeat the examination, just like a physical examination. So you did the exam yesterday, so you could skip the exam for the next 5 weeks. No, you don't do that for the physical exam, right? I mean, you go to the bedside, you do examine the patients every single day or every single time you visit the patients. So you can repeat every day, anytime, and you can monitor patients with these examinations. I can tell you, I sometimes do almost every day echocardiogram, and it blows my mind. Sometimes EF was 30%, 20% on day 1, and day 5, EF back to normal. Sometimes I've seen this. It's quite amazing. And sometimes we do RV examination with point-of-care ultrasound and adjusting the PEEP, and we are kind of aggressive guys, even doing a TEE in the ICU. That's a separate topic. But the beauty of the POCUS is you could do the examination anytime you want. And you don't have to worry too much about the disinfections. You have to disinfect the machines, but you don't have to worry too much about disinfecting the CAT scan, MRI, etc. And you don't have to worry about the radiation exposure. And it's really nice to check the patient's conditions in a casual way. I already show you these slides, right? And this lung and the venous and the hearts and the procedures are all valid for COVID examinations. And in particular, lung examinations. I would like to stress or focus mainly on the lung examination, right? So this is a classic article published 13 years ago by Daniel Lichtenstein. He's a French intensivist, and he's a founding father of the lung ultrasound. And he published the protocol to assess acute respiratory failure by the protocol called Brew Protocol. Brew Protocol stands for bedside lung ultrasound in emergency, and this is it. You combine 5 or 6 key concepts or findings to narrow the risk of the differential diagnosis for the patient with acute respiratory failure, like landsliding, A lines, B lines, C profile, and PLEPS. Don't worry too much about each terms, but I'm going to examine and explain a few things. And first, landsliding, which is basically to examine that the visceral pleura and the palatal pleura is sliding to each other. You see this white line here, horizontal line, that's a visceral pleura and a palatal pleura. In ultrasound world, white is always thick membrane, bony surface, or air. That's it. All right, so this has to be either thick membrane, bony surface, or air. And indeed, this is a thick membrane. It's a pleura sliding to each other. Okay, so what? Well, if you see this, you can almost 100% rule out pneumothorax. Extremely strong findings. Okay, so we do this. It's there, no pneumothorax. And you see this, artifact called A profile or A lines. If you see that's the point you're examining, so I'm using this probe, and the point you're examining is fine, normal. There's enough air, no pneumothorax. So I confirm this, and then I check the leg vein. Okay, there is no DVT. Good. And then I'm going to take a look here on the lateral sides of the chest. And I see something. I do see liver. I see diaphragm. And almost this looks like almost liver-like structure and a plurality and a blackness. Black is always water. Okay, remember black is always water or blood in ultrasound or shadow. So this is water, or this is pleural effusion, and this liver-like structure is indeed wet lung. So now you got the diagnosis. Oh boy, this could be pneumonia. So that's how we make the diagnosis. And in fact, it's better than chest X-ray. This is the article 17 years ago by Daniel Lichtenstein showing some sensitivity specificity of point of care ultrasound or lung ultrasound in general. So you see B lines, which is a vertical, white lines, which means lung is wet. And it's a very sensitive findings. It's even better than CT from time to time. And you see, I just show you the consolidative wet lungs. And this is a wet lung. You see white is air, thick membrane, or bony surface. And in this case, it's an air bronchogram inside the wet lungs. And this is a very good tool to diagnose the wet lung or consolidation. So why don't we utilize this in the COVID-19 patient? Can we make a diagnosis by utilizing lung ultrasound? And we could. You see all these white vertical beams arising from the pleura, and it's called again B lines. B for Kali B lines, kind of similar concept. And it's a B lines from the COVID patient has a very unique patterns, like confluent B lines, like a 2 B lines merged together, like you see it here, or you see numerous B lines we call glass rockets. Or sometimes B lines are so much to the point, you can't tell the difference of one B lines to the other. All the intercostal space looks completely white, right? So these are the patterns. And some people are wondering, I still don't get it. I mean, everything looks same. Oh, let me try to convince you a bit more. So this is non-COVID patients. This pleura, white line, white again, and white is the thick membrane body surface or air, right? The thick membrane pleura looks a little bit smooth. I don't know if I could convince you. But look at this COVID patients. This white line is disconnected, lumpy, bumpy, right? So this is a very characteristic findings for the COVID lungs. And not only that, this is the lumpy, bumpy lines of the pleura, but you could also see blackness right beneath the pleura, and we call it subpleural consolidation. And the black is water, remember? So which means that beneath the pleura, there is a wet lung. So that's a very unique findings on the COVID. So since I started seeing the COVID patients in March of 2020, and of course, I'm a POCUS guy, I started doing a POCUS lung ultrasound, I noticed few patterns. And I talked to my colleague, Dr. Kosuke Yasukawa, he's ID attending, and also hospitalist ID attending in Georgetown. And we are talking about that. You see this pattern, right? And we together wrote this article published last year. Hey, we do see certain patterns. We see like a glass lockets, almost all the COVID cases, confluent B lines, and a thick, irregular, lumpy, bumpy pleural line. So we see these patterns in a COVID patients just for 10 cases, but we thought it's interesting, so that we, merged the data and we published. So these are the typical findings for the COVID patients. Lung ultrasound, thick, irregular pleural line, and a confluent B lines, which is a vertical white lines you see it here. Subpleural consolidations, blackness right beneath the pleura, and absence of pleural diffusion. And the below variant is also called white lung. So all the intercostal space looks completely white by the B line. So let me ask you a question. So I'm going to give you 2 cases, right? This is case 1. You see the heart. I'll tell you the hint. One is a heart failure, and one is a COVID lungs. Okay, this is a case 1. This is a heart, and the right side is a lung ultrasound. And the case 2, this is a heart. The parasternal long axis B, what you're looking at is LB, and this is the lung ultrasound. So which one you think is, and which one you think and the is the COVID cases? Case 1. So let me type in case 1 or case 2. Which one is COVID?
Feel free to type in the chat or just shout out.
Yeah, so this is case 1, and this is case 2. One is COVID, one is heart failure. So Tina mentions case 1. Ali also mentioned case 1. I knew. There's an 18-beard mass group voted for case 1. I know there's a smart audience here today because I'm back in BI. So I knew it. Everyone's super smart. So, okay, excellent. Yes, indeed, case 1 has a COVID-19, right? You see what I mean? You see the pattern, and it's so obvious. Well, but let me tell you, it's kind of quite important. I can't tell you how many times I got a phone call from the ED. Hey, this poor old lady needs to be admitted because of the COVID pneumonia. Okay, patient has a fever from nursing home. Okay, sounds like a COVID-19. All right, and the lung is completely flat, ARDS. Okay, all right, so she's intubated on ventilator. Now it's your job. You figure it out. Okay, well, that's my job. Okay, I'll figure it out. So I do the POCUS, right? And sometimes the picture looks exactly like case 2. Heart is like this. And lots of bilateral smooth pleural line, bilateral B lines. So do I give dexamethasone? Do I give remdesivir? No. I give Lasix, right? So I give Lasix and the patient gets better, extubated next day. Why? Because it's acute pulmonary edema due to heart failure. So it's not COVID-19, and later on PCR came back negative, but back then, December, January, everyone's COVID. Nursing home, COVID. But a broke bone, no COVID. No, everyone is labeled as COVID. So you gotta be careful. And indeed, you're right in assuming everyone has COVID. Yeah, it's a right attitude, but sometimes there's a non-COVID patient which can be managed easily by Lasix, right? So it's important. Now we developed this concept of the lung ultrasound. We make a scores, right? This is the Blue Journal 3 years ago explaining lung ultrasound score, right? So 0 is normal lung, 1 is like 1 B line or 2 B lines, or 3 B lines, 2 is more B lines, and 3 is consolidation. So we score 0, 2, 1, 2, 3, and we divide right lung 6 segments, left lung 6 segments. So we have altogether 12 segments, and we score each findings. So the total score, the maximum score should be 36. Why is that? 3 times 12 is 36. 6 segments, all 3 consolidation, then 36. Technically, it's possible. And the minimal score is 0. So that's how we scored lung ultrasound findings. So we did that. For example, like this one. Oh, looks like normal. 2, okay, normal. Oh, lots of B lines. And this one has also a lot, not B lines, it's a consolidations. And section 5, we see a lot of consolidations. And the section 6, it's a lot of consolidations. So how do we score this? So it's normal, alveolar interstitial patterns and consolidation. It's at 0, 0, 2, 3, 3, 3. So that's the one lung is 11 scores. If the other is same, then total score would be 22. So that's how we utilize the lung ultrasound scores. And how, okay, got it. But how do we utilize for COVID patient? Well, we may predict critical causes. And interestingly enough, this group in Israel almost did the exact same study, slightly different. And just before we published our data, they published in intensive care medicine, which has a much higher impact factor. And they did a wonderful study. Oh, my time is running out, so I will speed up. I know. So based upon the score, we could predict the outcome. So that's their conclusion. And we did the similar study. So we analyzed 100 COVID patients. We all did the lung ultrasound score for all these 12 sections, right? And the 3 of us, Kosuke, myself, and the Ernest Fisher, we gathered together last year reviewing all these 100 patients. And we have, each patient has 12 images. So total of 1,200 images we reviewed, and we came to that we have to agree with the score. So that's what we did. It's a painful work, but we did that anyway, reviewing all these 1,200 images, made a scores, and we analyzed the data, and it has a very interesting findings that, hey, those whose lung ultrasound score is low on presentation to the hospital, those who are all admitted to the hospital because of the COVID pneumonia, probably wouldn't develop severe COVID. And those whose score is quite high, what do you mean quite high? 17 or above would likely require more invasive, intense respiratory therapy. What do you mean by that? Is a high flow nasal cannula, non-rebreathing mask, intubation, or mechanical ventilation. So by calculating lung ultrasound score on admission, we could predict some clinical outcome. So that's our conclusion. So the lung ultrasound score and the lung ultrasound, or more so POCUS in general, turn out to be quite helpful when dealing with COVID patients in the ICU or on the floor. Remember that the Kosuke and the Ernest Fisher, they are hospitalists. Kosuke is ID doctor too. They work in a general medicine floor. They use POCUS all the time. I work in the ICU dealing with all these super sick COVID patients. Turns out it's super helpful. So I hope, and I know the time is a little bit rushing, but I hope I could convince, or at least I could give you some impression point of care ultrasound for the patients with COVID-19 is quite useful. So let me move on to the third theme and the third and the last learning objective, innovative application of point of care ultrasound. And when I talk about innovative application, I have to talk first about innovation in hardware. And then I'm going to talk about innovations in the software parts. What do I mean by that? All you'll learn in a minute. So this is a viewpoint published by my dear friends, Neelam Soni, who wrote, by the way, amazing textbooks, a point of care ultrasound that I think that got the award. And and he and I actually started the point of care ultrasound course in Japan. He and I are co-directors. We started the course 4 years ago, and it got super popular. But unfortunately, because of the COVID, it's kind of on hold. But anyway, so Neelam published these textbooks, and I translated his book into Japanese. So this is a roadmap, and ultrasound is only used by the cardiologists in 1960s, then OBGYN in the 70s, 80s, emergency medicine 90s, followed by us critical care guys in late 90s, 2000s, and anesthesiology, medicine, pediatric med students, APP nurses, all providers, probably by 2020, which I would say that's a fair assumption. And that comes with the smaller, cheaper, and higher quality machines. So back in 70s, 80s, we had these big rigs. It's very expensive. How expensive? Like, we are talking about $2,100 or, $2,300,000. You can buy Porsche or Ferrari, right? So that's, and a big, huge, and I still remember when I was a fellow, we still have this kind of, big rigs in the ICU, and I have the consult from, cardiothoracic ICU, which is in the downstairs. It's painful in the middle of the night to bring these big rigs down to the cardiothoracic ICU. But anyway, it's a heavy, expensive, quality is okay. And in a mid 2000 to 2010, and actually this machine comes 2009, comes this revolutionary smaller machines. It's much more reasonable price. Well, still 40, 50K, but the quality, image quality was just amazing. That this came when I was a first year fellow, so that should be 2008. And we are all grown up. Holy cow, this machine is so cheap, so small, but image quality is amazing. And that's kind of revolutionized the movement of point of care ultrasound. Here comes 2018 or so. You probably know, you heard about these smaller devices attached to the iPhone or tablet, and it's amazing. We hospital have these devices, and I've used it from time to time. It's amazing that it's so cheap. So cheap, first of all, like roughly around $2,000. Much cheaper than $40,000 or let alone $200,000. Much smaller. You could put it in the pocket and you could go to the bedside and examine the patient. So innovation starts from hardware. That's really the key. However, I'm talking about innovation in a software, and mainly just briefly because I have a few minutes left. AI, artificial intelligence, to diagnose COVID-19. And this is my dear friend, Rob Arnfield. He's an emergency medicine guy in Canada. And we work together at Point of Care Ultrasound Training. And he also one of the authors of the Point of Care Ultrasound, the textbooks, one of the co-editors. So Rob published this amazing article this year about the neural network and a convolutional neural network. And I have to tell you, I'm still studying this area, new area, but I just wanted to share my excitement. It's so fascinating. So basically, every image is a matrix, right? That's by the way, new movies coming out. The CAT scan is a matrix, right? CAT scan is 256 times 256 matrix, and each matrix has its number called Hounsfield units. Nowadays, the resolution is a little higher, 512 times 512, and we have high-res CT, which has 2048 times 2048. But either way, it's a matrix of the numbers. So we kind of capture this image and degrade it into, in this case, 28 times 28 matrix. And each matrix carries a number based upon the graduation. It's a black, 0, white is 1, and a gray is somewhere between 0 to 1. So we put the numbers, and we put that, 28 times 28 matrix, and we weighed each matrix into the next matrix, to the next matrix, and finally come to the output of 0 to 9, so that the computer could guess based upon the learning process whether this image here, it looks like 2, is most likely 2 or 1 or 3. And the computer would say, well, 10% is 1, 70% is 2, and 20% is likely 3. So that's how it says. And then you let this neural network learn from the right answer. Hey, listen, this is actually 2. Remember that? And then they're going to reweigh the neural network. So that's how they do that. And the genius of Artfield is they actually utilize this COVID lung ultrasound and non-COVID ARDS picture. Using this methodology, let the computer learn and create the AI. And guess what happens? It's quite amazing. Well, I'm going to skip this GradCam heat maps, so who cares? But this is a result. The red is human and yellow is computer or AI. So what do you think? This ROC, receiver operator characteristics. They're actually quite impressive, right? They let the computer learn these COVID images, non-COVID ARDS images, and now AI can tell, hey, boss, looks like this is a COVID lung, or hey, boss, this is likely not a COVID, maybe cardiogenic pulmonary edema, or this is non-cardiogenic pulmonary edema. So it's quite amazing. So it goes back to this, to my question. Hey, when you take a look at these two cases, you see this nice hyperdynamic echocardiography LB and this, confluent B lines. This cannot be cardiogenic pulmonary edema. So this has to be something else. But if you see this, oh, look at this. Look, is LB working? Well, yeah, it's working, but EF is 15%, by the way. It's an interesting case. But anyway, and you see this smooth surface pleura and some B lines. Then, oh, this is more so consistent with cardiogenic pulmonary edema. The point is, now the machine is learning this algorithm by using convolutional neural network. It's a quite amazing process. So with strong performance with AI, maybe in the future, they could help us make the diagnosis by reviewing, let the machine review the images. And by the way, it's already started in a mammogram, right? So it's quite amazing process that now AI can look at the lung ultrasound, may tell this is likely COVID-19 or non-COVID-19. So in summary, point-of-care ultrasound for COVID-19 and a point-of-care ultrasound in general, meaning that ultrasound by you for your patients, an extension of physical examination. Who's going to do that? You're going to do that. Which patient? Your patient. Who's going to read the images? You're going to read the images. You assess for your patients. So that's point-of-care ultrasound. And lung ultrasound is among the tools of point-of-care ultrasound. It's extremely useful to evaluate the patients with COVID-19. Key findings is a thickened irregular pleura, lumpy, bumpy pleura, glass lockets, confluent B-line, subpleural consolidation, fight lungs. We further fine-tune these findings into the scores, which could be a useful tool for the prediction of clinical outcome of the COVID patient. And a machine learning, it's just started, but it's coming, and I could see this is a big movement, innovative way to process the images. Better than human, we'll see to the diagnosis in the near future. And evidence, more to come. Stay tuned, and thank you so much for your attention. That's it.
Excellent. Thank you so much. That was
okay.
You did it, and you did it on time. We have about 9 minutes for questions. Maybe I'll let people,
Am I on time? Yeah, okay. I have 9 minutes. I'm sorry. Minutes passed for the Q&A.
You did perfectly.
Okay, thank you.
We'll open up the floor if people want to unmute or add something in the chat. Maybe while we're waiting for people to unmute, I'll just ask you a little bit about, you talked a lot about sort of the role in COVID-19. Hopefully the frequency of COVID-19 infections will diminish over time. Mm-hmm. How do you see this working, either in the ICU or on the floors or even in the outpatient setting, separate, besides COVID?
Yeah.
What are sort of the other disease states that have demonstrated some value for this?
Oh, yeah. So that's a great question. Thank you so much. So it's kind of even funny or almost synchronistic because I just finished podcast in the clinic. Today I have clinic, a whole day clinic. Yesterday, they're abusing me. As a weekend, I was working in a step-down unit. Today I'm working overnight. I did ICU overnight on call, and today I'm working in the clinic. But anyway, so I just finished podcast with one of the patients with diaphragm dysfunctions. And this is a place, this is also another perfect example. How do you assess diaphragm dysfunction? And people say, well, fluoroscopy, maybe. Oh, EMG. Oh, neuroconduction study. Yeah, you could do that. But the point-of-care ultrasound is a great tool. I can see the diaphragm thickening directly with my own naked eyes. I just diagnosed and just assessed a very interesting case. I can't tell in detail. There's a very unique, drug side effect causing diaphragm dysfunction. And I could observe this diaphragm function getting better over time in the clinic by using point-of-care ultrasound. I didn't order ultrasound or, my EMG or neuroconduction study. I could do it here in the clinic real time. So that's one great example. The other assumption, and sometimes I do echocardiogram, as the augmenting physical examination for the cardiac examinations. And then very often, I have these patients. So you probably agree that the cardiologist says that, oh, your heart is perfectly fine. Your trouble breathing is not from the heart. We are done. Go figure out pulmonologist, right? So these people come to my clinic, and really seriously, and this patient, JBD and leg edema, and you have that dyspnea when you're lying flat. Yeah, I have motor breathing. Really? So history fits more to the heart failure. So I do the echo exam myself, and sometimes, and also I review the echo reports, right? And sometimes the people miss so many times about diastolic dysfunction, for example. That's so much black hole. Everyone loves EF. EF is normal, word is perfect, right? And I hate that statement. So hey, you forget about diastolic dysfunction, which explains 55% of the newly diagnosed heart failure. So I do my own examination. I can't tell you how many times I pick up grade 2, grade 3 diastolic dysfunction, send the patient back to the cardiologist. Say, you know what? You go review these patients once again, my friendly neighbor. And so it's also quite helpful to re-examine the possibility of dyspnea on exertion or unexplained dyspnea on exertion. Sorry, baby, I'm talking too much.
No, that's great. Dr. Berger.
Yes, thank you. I have a question. It may be a little out of your area of expertise, but you did bring it up. So I just when we talk about augmented intelligence, artificial intelligence, whichever way you want to view the CAT scan and computer assisted reading.
Uh-huh.
I love it. I think it's great, but one of the things I worry about sometimes when you see some of the rules applied to imaging is that they're applying conformational biased rules, right? Opinion, I believe it's this, so the computer has to believe it's this.
Yeah,
so we're talking about something like COVID, which does look on the CAT scan like a lot of other things.
Yes.
It looks different than a bunch of things. How did they, in the studies that you talked about, how did they correct for that or account for that potential of bias, that there are a lot of things that cause ground glass and interstitial patterns?
Yeah, so that's a great question. So because, you know, I talk about the convolutional neural network and the learning process because the learning based upon some answers, right? And so your question is basically, if the answer is garbage, how do you trust this, you know, learning process? Basically, I mean, it's basically that's how I took your question is. So how do you get rid of the biases? How do you know that you present is the right answer is true right answer? That's a great question. I think they mentioned in the discussion, I have to go back, but that's one of the weakness, always comes with a weakness, right? That comes, it's one of the major weakness of the AI and the neural network in general. You have to present the right material, because if you want to let the AI to learn the picture of the cat, you have to include the picture of the cat, not the dogs or the spiders or, you know, the snakes, right? So you have to present a picture of the cat. Same thing that you have to present a picture of the COVID-19. So when it comes to, let me see if there's one good example. So say you say this is a non-COVID ARDS. How do you know? I mean, well, it's based upon the clinical and a clinical judgment. Are you 100% sure? I'm pretty much sure there are cases which turn out to be later it's a COVID, or that we believe it was a COVID, turn out to be not COVID. That could happen. You know, like I told you that cases that's presented from the ED to the ICU, hey, we have a COVID ARDS, severe ARDS due to COVID. So, and it turns out to be a simple cardiogenic pulmonary edema. So this error and a bias could migrate at any point. And the best way I would say is to always keep the good mind of suspicions. So I'm not question. I'm fully answering to your question. That I think your point is a great point. Whenever we employ the new technology, and the technology is technology, and I teach point-of-care ultrasound, and I tell them this is not the magic wand that gives you every single answer. It's still history matters, right? And history matters, physical exam matters, and it depends on how you're going to utilize this tool to your everyday practice. So it's not that, you know, like a 1984 situation that a big brother dominates you using some specific system. No, but it's a tool. So it's really up to you how you're gonna utilize. But I'm sorry, it's maybe I'm talking too much. Sorry.
Oh, that's great. We have 30 seconds left. You have one more question in the chat. See if you can do this in 30 seconds. Do you have a preferred protocol or approach for POCUS and undifferentiated shock?
Oh, yeah. So that's a great question too. So the short answer, rush is becoming the kind of the preferred approach to the differentiation of the shock. But I always tell this, there are 17 different shock approach by point of care. Also, everyone wants to name that, hey, this is Taro approach or something like that, for example. So rush, falls approach, and you know, there are 10, 70, 18, I think one article counted and 17. So I would not, my message is this, don't worry too much about each specific protocol, but get back to the principle. Shock always comes from hypovolemic shock, distributive shock, cardiogenic shock, and obstructive shock. And you always think about 4 differential diagnoses and think about how you're going to utilize POCUS to rule out or rule in. And also combine the epidemiology, right? And based upon the New England Journal of Medicine 2013, Jean-Louis Vincent, the sepsis guy, published the data. The most of the cases, shock cases in the ICU, 62% is coming from septic/distributive shock, 16% 16% volume, hypovolemic shock and a cardiogenic shock, and obstructive shock is only 2%. So, think about epidemiology, think about the principle. That's really most important thing. So, my short answer, maybe I could say RASH might be a preferred protocol nowadays, but I may not care too much about which protocol I'm going to use. I'm going to always think about what differential diagnosis, epidemiology, and put focus into the practice. I hope I'm answering to your question.
Sounds good. All right, we got to quit. It's 1:01. Thank you so much.
My
Excellent
pleasure.
talk. We really appreciate everything